Good morning, good afternoon, good evening, everybody. I am hearing that you're seeing your menus in Spanish, so we are looking at that, but we don't know what that could be. And it is certainly not because I'm from Spain, okay? That is just a coincidence. Sorry to see that happening. We don't know, it's maybe another virus. I don't know if it is a coronavirus or another one in the web that is playing games with us. In any case, we're going to start the event right now, and sorry for that. Everything else is going to be in English. The handouts are in English, as you have seen, and obviously the presentation will also be in English. So I'm going to start by saying that if you have any questions, you can submit the questions in our Q&A panel. Many of you have done that when commenting this Spanish issue, and we will be answering these questions at the end of the event. My name is Fernando Yuste, and I am in charge of professional clinical education with Medtronic. I've been doing this for many years. Before this, I was a medical physicist in a hospital in Madrid, Spain, and I also have some education on marketing organization. I'm going to start presenting Carla Ljungqvist, the first one of our speakers. Carla has been working. Oh, sorry, sorry about that. Carla is an associate professor at the University of Buffalo School of Nursing. She has done research as a nurse and nurse practitioner in the area of safe and effective pain management for over 30 years. She has dedicated her professional service to the American Society for Pain Management Nursing, where she was lead writer of the ASPMN clinical practice guidelines for monitoring hospitalized adults for opioid-induced respiratory depression. She's a fellow of the American Academy of Nursing, inducted for being recognized as a national leader in behavioral therapy for sleep and pain disorders, as well as improving patient safety with opioids in the hospital setting. Dr. Khanna is a staff intensivist in anesthesiology and associate professor of anesthesiology in the Department of Anesthesiology section of critical care medicine at Wake Forest University School of Medicine in Winston-Salem, North Carolina, where he's also the section head for research. Dr. Khanna is heavily involved in the AASA, the Leadership for Critical Care Medicine, and the SCCM, Society of Critical Care Medicine sections, committees, and task forces, and has received the SCCM presidential citation multiple times. He has authored more than 80 peer-reviewed papers and 24 book chapters, as well as several invited editorials, non-peer-reviewed articles, and online educational videos. He has been invited to talk about his work at prestigious national and international forums. His research interests include detection and prediction of postoperative respiratory and cardiac events on the hospital wards, outcome of hypotension in critically ill patients, and use of novel vasopressors in shock states in the ICU. As disclosures, both speakers have received funding from Medtronic. The Prodigy trial steering committee and research grant funding has been sponsored by Medtronic, but here this is about their opinions and solely the opinions of the speakers, and they were responsible for all content and any necessary permissions. This is a CME accredited event. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education, ACCME, through the joint providership of Synaptive and Saxe Healthcare Communications. Synaptive is accredited by the ACCME to provide continuing medical education for physicians. Synaptive designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in this activity. We will show you how at the end of the event. This is also accredited for nurses and respiratory therapists. With that, let me join me welcome Dr. Aziz Khanna. Dr. Khanna, you're in charge.
Thank you again, Fernando.
Hello.
Thanks for having me, and it's an honor and a pleasure to be here. Again, I know you all are tuning in from all over the country and all over the world, so good morning, good afternoon, and good evening. And today we're going to talk about the derivation and validation of a novel opioid-induced respiratory depression risk prediction tool. We're going to talk about the Prodigy trial and its real-life implications and how it's going to affect patient safety and patient care all over the world. Some learning objectives for my presentation essentially focus on describing implementation strategy for continuous respiratory monitoring, discussing challenges associated with the prediction of respiratory compromise post-operatively, and recognizing patients who are at risk for respiratory compromise. So what is the issue at hand? The issue at hand is that our patients on the general care floors continue to have serious cardiorespiratory events. Literature has shown that nearly 90% of postoperative mortality occurs on the general care ward and not inside ICUs and other acute care areas. Other literature has also shown that about half of all of in-hospital cardiorespiratory arrests occur on general care floors. Looking at all of the reasons why patients have cardiorespiratory arrests on general care floors, opioid-induced respiratory depression, or OIRD, is one major potential cause of these events. And OIRD is important. It's important firstly because it increases patient length of stay. Some literature says about 5 days or so. It increases readmission rates to hospitals. And most importantly, in today's day and age, it's associated with increased healthcare costs. It is obviously also associated with higher mortality. And the higher mortality story is interesting because a lot of this data comes from registries such as the Get With the Guidelines registry, where investigators saw that nearly 40% of patients who have acute respiratory events on inpatient wards do not make it out of the hospital alive. What causes these respiratory events is either opioids in of themselves or significantly opioids in a dangerous cocktail combination with sedatives and mood-altering drugs. And we all know how common that is for our patient population these days to be on this deadly cocktail that they get administered about the same time, and that results in a code blue event at the middle of a night. The issue is developing predictors or how to prevent OIRD. When I talk about that issue, understand that code blue events or acute events on hospital floors don't just happen out of the blue. They're usually preceded by several hours of a gradual change in vital signs. It's a pattern change that happens over 4 to 6 or 8 or even 10 hours. And the majority of the patients will have this gradual pattern change. However, using intermittent spot check monitoring, as we are doing in most parts of the country and most parts of the world, where every 4 to 6 hours a healthcare provider will go in and check in on a patient, is not good enough, and it's not going to pick up most of these gradual changes in vital signs. In fact, a closed claims analysis shows that, up to about 97% of opioid-induced adverse events were adjudicated to have been preventable had we had better education and better surveillance monitoring. Now that all of you understand the landscape of this problem, let me go into a little bit more detail of how the intraoperative period plays out to postoperative morbidity and mortality. The intraoperative period is really, really safe these days. In fact, intraoperative mortality is so low after elective surgery that it's difficult to quantify it and actually give it a number. It's in the decimal points. However, the postoperative period is not quite there yet. These authors used the period within 30 days of admission for surgery as a disease entity in and of itself, and saw that it was the third most common cause of mortality in the United States, only after diseases of the heart and death or diseases of related to malignant neoplasms. The issue is, again, that our general care floors that are traditionally perceived as areas where patients who are more medically and surgically stable will recover and actually go home are probably not quite as safe as we perceive them to be. There is unseen and unheard hypotension and hypoxemia that happens all the time on the general care floor. When it happens, it's common, it's profound and prolonged. The other big deal is that it cannot be reliably predicted, at least based on some of the tools we have today based on literature. Also, if we look at the specifics of acute respiratory and cardiac compromise, it gets more complicated because there is a large amount of patients who will not make it out of the hospital alive when they have these events. Even if they're resuscitated from a code blue event, they will not make it out of the hospital alive. The other issue is that heart attacks, or primarily cardiac events, are most of the times silent in the postoperative period. They're usually detected by a troponin increase, and that's all. And they're still exceedingly common and responsible for half of all deaths during initial hospitalization. So it's a complex and rather dangerous perspective that I present to you all today. But this perspective is backed by a lot of strong evidence. So let me get into the evidence really quickly. The first set of experiments here comes out of the group at Cleveland Clinic, where they looked at nearly 850 non-cardiac surgical patients that were monitored with continuous pulse oximetry monitoring that was silenced to the bedside provider. What the investigators found was that patients get hypoxemic all the time. The x-axis is hypoxic minutes per hour. So for about 10 hypoxic minutes per hour, at least a fifth of these patients were experiencing O2 sats less than 90% for that amount of time. And this was going unnoticed based on spot check monitoring. For about 20 hypoxic minutes per hour, there were at least 5% of patients that were seeing this, but it was going unnoticed because of spot check monitoring. If I look at it in another way, and I look at the episode duration and how much of this was being missed, about 90% of episodes with a hypoxemia threshold at 90% or less for about 1 hour of continuous monitoring in a 48-hour period were being missed based on spot check monitoring. Lots of numbers on this slide, but the headline here is important. Postoperative hypoxemia is common and disturbingly goes undetected most of the time. So we decided to investigate whether we can predict postoperative hypoxemia. One thought was that an increasing stop-bank score as a surrogate marker for obstructive sleep apnea would be probably also a marker for postoperative hypoxemia and the risk for postoperative hypoxemia. However, our results showed a different story. We saw, as you can see on these three panels here, for a threshold hypoxemia of 95%, 90%, and 85%, and an increasing stop bank score, the lowest score with the light green here and the highest score with the yellow here, the behavior of hypoxemia was essentially the same. Yes, hypoxemia was common, as my arrows here will show you, but the amount and duration of hypoxemia was not significantly different whether you had a low stop bank score or a high stop bank score. So stop bank scores could not be used to predict postoperative hypoxemia. The other issue along with obstructive sleep apnea that often comes up is the use of postoperative opioids. And in a similar experiment again, we showed that long-acting opioids on the red colored line here and short-acting opioids on the dark green here behaved entirely similarly when it came to thresholds of hypoxemia of 95%, 90%, or 85%. So again, while opioid-induced hypoxemia was common, it wasn't different based on the type of opioid that the patient was receiving. So to put it in a simple sentence, the amount and duration of postoperative hypoxemia could not be predicted using stop bang scores and using the type of narcotic a patient was going to receive for postoperative analgesia. So what is the answer then? Is monitoring an answer? Laurie Lee's group published this very heavily cited postoperative opioid-induced respiratory depression closed claims analyses. And the results made a strong point. They made a strong point because they said that up to 97% of OIRD in related claims were adjudicated to be preventable using a better monitoring and response system. Understand that I say not only better monitoring, I also say better response, because no amount of monitoring is good in and of itself if you don't have a response to monitoring. The other really interesting thing that comes out of their work is about half of their OIRD induced, or OIRD in and of itself, was adjudicated to be happening about 2 hours after the last nursing check. So understanding that most nursing checks happen at an interval about 4 hours, it was that time between when one nursing check has happened and the other one has not happened as yet, that dark area was the time when most events were happening. Now, can continuous monitoring prevent all of this? We really don't have great data to date. Whatever data we had is presented in the systematic review and meta-analyses, and it does show that continuous pulse oximetry monitoring is associated with an improvement of the detection of hypoxemic events on the floor. There is a trend towards less ICU transfers. The data on rescue team activation and mortality, especially mortality, is largely inconclusive. However, the ventilation part is really interesting. While capnography has not been adequately implemented to date, wherever it has been implemented, it has shown that especially in patients who receive additional oxygen supplementation, which we all know most of our patients do on the floor for one good reason or the other, capnography is associated with improved detection and does act as a viable early warning tool for these patients when they are in a respiratory depression situation. So what do we do? Can we simply just convert our general care floor into an ICU? Can we just put all our patients on continuous monitoring, let there be alarms all over the place, and let us all get into an alarm fatigue situation? The answer, as you all probably know, is probably not. There is a long way to go before we get to better continuous monitoring of all our patients. But right now, we have to decide who are our high priority patients and what parameters should we monitor on those patients. How we should best monitor it? I would say it should be portable and it should be continuous. But then we still need to answer everything else about making it less labor intensive and still preventing alarm fatigue while allowing for interventions based on alarms that go off on continuous monitoring. While I talk about prediction of respiratory depression in these patients, I have to say that there have been risk models that have been developed. Several authors over the last 10 years or so have examined risk models. These risk models are based on patient level characteristics, either from their medical history or based on their demographic, and look at outcomes that have been built into a logistic regression model. However, those outcomes are usually outcomes such as respiratory failure, pneumonias, pleural effusions, postoperative atelectasis, and so on and so forth. How does Prodigy differ? Prodigy is the largest prospective observational trial of continuous multiparameter respiratory monitoring on patients receiving opioids on the general care floor that used real-time patient data and respiratory data to build in a respiratory depression risk prediction model. This, to my knowledge, has not been done before, and this is where I feel a great sense of pride in introducing to you all the Prodigy trial that was just published in Anesthesia Analgesia this weekend. And I will be talking to you all about the Prodigy trial, and Dr. Youngquist will follow up with specific details on real world applications of this trial and its results in her presentation. So, what was Prodigy? Like I said, Prodigy enrolled about 1,500 adult patients at 16 sites in 7 different countries in the US, the European Union, and Asia. Patients who were adult patients and expected to receive parenteral opioids while on the general care floor. Our final analysis set was actually 1,335 patients, all of whom received continuous monitoring for a minimum of 1 hour and a maximum of 48 hours with periodic checks by the research and nursing staff. And 1,282 of these patients completed a full follow-up at 1 month after study completion. What did we do? After enrolling these adult patients who were expected to receive opioids on the general care floor and parenteral opioids at that, we ensured that all these patients were not only on monitoring, we also had all these monitors continuously blinded and silenced to healthcare providers. So providers did their regular 4 to 6 hour checks per institutional norm, whereas the continuous monitor required and acquired all of this data in the background silently. All of this data was then sent to an independent clinical event committee comprised of 3 or 4 experts in perioperative respiratory depression who adjudicated the vital signs data and the waveform data to say this is a real event, this is a false alarm, and this is an opioid-induced respiratory depression episode. How did we define an episode? Without going into great details, we used at least a time duration of 3 minutes for a low respiratory rate less than 5, an SpO2 less than 85%, or an end-tidal CO2 less than 15 or greater than 60. We used any apnea episode more than 30 seconds, and we used any predefined respiratory opioid-related adverse event. We use 46 potential a priori defined predictors in a model where we used to predict respiratory depression episodes based on the adjudication of the clinical event committee. And we developed the Prodigy risk score using all significant predictors in a multivariate risk prediction model. This is the Prodigy risk score, our primary outcome for the Prodigy trial. It is a really simple and easy to implement risk score. 5 variables. Most importantly is age greater than the age of 60, with every decade of age increasing risk. This is the biggest driver of the risk of opioid-induced respiratory depression. In addition to age, male sex, opioid naivety, sleep disordered breathing, and the presence of chronic heart failure made up the rest of the risk prediction tool. As you can see, it's a very easy to use tool. You and I could just use it at the bedside anytime and not need complex calculators or to go into complex web-based calculations for this risk. I'll give you an example. If your patient is, say, 65 years of age and has chronic heart failure and is a female, so we haven't marked male sex here, we go over to the other side, we look at the amount of risk attributed to this. Age between 60 and 70 is a Prodigy score of 8 over here. Chronic heart failure is a Prodigy score of 7 here. A total score here would be 15, which would be the highest risk category on the Prodigy scoring system. So less than 8 is low risk, 8 to 15 is intermediate, 15 is the highest risk. This patient would have about 6 times higher the risk of opioid-induced respiratory depression compared to, for example, a same patient who would have been less than 60 years of age and not had chronic heart failure, right? So those are an easy to use real world applicability of a simple tool like this. Going on further, we've developed and we continue to develop real-world applications for this tool. This kind of interactive PDF would make life so simple for us, where we could just fill in patient data, an example that I just showed you, and come up with a total risk score, and then decide how and when we should best monitor our patients and what we should do for them proactively to improve outcomes. Dr. Youngquist will actually talk a lot more about the actual interactive risk prediction tool and how it can be used in clinical real-world practice. Our model was accurate. Our model had an AUC ROC of 0.76. That is really accurate for a model that predicts something as complicated as respiratory depression in the post-op related to opioids on medical and surgical patients. Our observed and predicted probability of RD on a calibration plot was also very stable, and the fit was extremely good. Furthermore, we had secondary outcomes. We wanted to individually characterize and understand whether end-tidal CO2, SpO2, and respiratory rate alone or in combination increased sensitivity and specificity of outcomes. We also wanted to use the integrated pulmonary index, which is a complex fuzzy logic tool that comprises EtCO2, SpO2, respiratory rate, and heart rate to understand whether IPI as a single number is better at predicting respiratory depression episodes. Importantly, we also looked and compared the risk of patients with and without RD for overall incidence of actual clinical adverse events and for healthcare resource utilizations. Some of this data is already published as a part of the full Prodigy paper, and other economic models are on their way and will be published during the rest of this year. Importantly, I want to talk about respiratory depression episodes. A question that has come up again and again is, yes, great, up to 46% of our patients in the Prodigy trial experienced respiratory depression episodes as detected by continuous monitoring. Now, how did they translate into real-world clinical outcomes? We saw that even though there was a small percentage of patients that progressed to more serious adverse events, but patients who had respiratory depression episodes, and 46% of our cohort had respiratory depression episodes, they showed evidence of poorer outcomes. For example, patients with one or more than one respiratory depression episodes were more likely to experience an actual adverse event that required intervention compared to patients who did not experience RDEs. So, for example, there was a 36% higher risk for adverse events that needed prolonged hospitalization and nearly a 2.5 times increased risk for the likelihood to experience any of these adverse events, such as rapid response team activation, rescue events with reversal agents like Narcan, and positive pressure ventilation on the floor. Also, patients who had monitor detected respiratory depression episodes, again 46% of our cohort, had a mean hospital length of stay that was 3 days longer compared to patients who did not have these respiratory depression episodes. The other issue is costs. How do we translate Prodigy data into costs for hospitals and patients alike? Those results tell a very important story. Average hospital costs for US patients with one or more respiratory depression episodes detected on this monitor was about $5,000 higher on an average. When we looked at patients with one or more RDEs in the Prodigy highest risk category, that mean cost was $6,500 higher than those without RDEs in that high risk category. Those data translate into a significant p-value for all US patients with or without outliers as seen on this table. And because pictures actually tell a better story than lots of numbers, in the blue are patients with one or more respiratory depression episodes as picked up on the continuous monitor. And as you can see, all US patients and patients excluding outliers who would have extremes of values, both of these data sets clearly show that there's an exponential increase in total costs, healthcare associated costs, when patients with one or more respiratory depression episodes have increased hospital length of stay, and that they do by a mean of about 3 days as compared to patients without respiratory depression episodes. With that, I come to the end of my section. To conclude, I'd like to just summarize and say respiratory depression episodes are common. We know that intermittent monitoring does not do a good job in detecting all of these events. And while respiratory depression episodes picked up on the monitor might not be equated to actual clinical events, they do, as we have shown in the Prodigy trial, increase risk of adverse events, increase the average hospital length of stay, exponentially increase hospital costs. We have developed a Prodigy risk prediction tool based on the results of the Prodigy trial. It's easy and can be used at the bedside to predict RDE episodes. Up to 46% of our patients had these episodes, and patients at increased risk on the Prodigy score will definitely benefit from proactive bedside interventions that will include better continuous monitoring in an effort to proactively intervene and prevent further disaster from happening. I thank you for your time today, and I'm open for questions afterwards. We'll turn this over to Dr. Youngquist.
Dr. Youngquist, you need to unmute yourself.
Oh, thank you, Dr. Khanna. So Thank you for that good explanation of the instrument. And now I want to talk about how we can apply this to clinical practice and to the bedside. So in particular, I'm going to go through some slides that review some of the ASPMN guidelines, the American Society for Pain Management Nursing guidelines that have just been released. So let me start by saying that these acute respiratory events are still a problem. We need to address this, and we need to recognize patient deterioration earlier. So according to this study, the Cardoso study, for every hour of waiting to recognize respiratory depression, the risk of death in the ICU increases by 1.5%. And it's up to us nurses at the bedside to be able to recognize this patient deterioration. Let me show a picture here. This is a graph of end-tidal CO2 and pulse oximetry on the patient. So this is end-tidal CO2, this is pulse oximetry, and this is over time, 9:57, an adverse event occurring at 10:10 where Narcan was given. You can see that there is a rising CO2 level. Pulse oximetry doesn't really do too much until right before the event happens. Within 6 minutes of the event, you can start seeing some decrease in oxygen desaturations. So if you can tell from this that really just using pulse oximetry is a real problem for us at the bedside. We do need a better way to look at the data, trends over time, and to recognize which type of monitoring system would be best to help detect early detection of patient deterioration. So another point I want to make is that opioids aren't going away. Although opioid-free analgesia and multimodal analgesia are really important concepts that we must follow to improve patient safety, opioids remain a key component to multimodal analgesia. So there have been many organizations that have attempted to address this problem. And in particular, I'm going to talk about the American Society for Pain Management Nursing guidelines. These guidelines were just published earlier this year. ASPMN is one of the leaders in developing and disseminating best practices for safe and effective pain management. The revisions to the 2011 monitoring guidelines are now available at Pain Management Nursing, and these guidelines will serve as the minimally accepted standard of care for patients. So what that means is when adverse events and bad things happen, attorneys are going to look to these guidelines as the standard of care. So I'm going to go through just some of the guidelines, not all of them. You can certainly go to the manuscript for all of them, but the ones that are key pertinent to this talk. So recommendations 1 and 6 are directed at always using evidence-based practices, multimodal analgesia to ensure safe and effective pain management. Anything that's opioid sparing but allows for good pain management is the goal. The second and third recommendations, these recommendations speak to the real threat of all formulation of opioids. So we know that parental opioids are of higher threat, but we also know that adverse events happen in people who are taking oral opioids. All patients should undergo a comprehensive risk screening for risk for OIRD, but screening doesn't stop there. We must continue to revisit risk ongoing. So for example, a patient that requires a high dose of opioids, we can't predict that before surgery or before hospitalization. So we need to have iterative reassessments going on that adjust the monitoring strategies that we choose. Recommendation 4 states that we should be individualizing plans of care, empowering nurses with the knowledge and skills to apply continuous electronic monitoring to promote safest care. We also don't want everybody tethered to their bed. That all plans of care should be readdressed on an ongoing basis. The plan should be driven by your assessments. Communication is a must and should be supported verbally as well as within the electronic medical record. Now, let me talk about some specific factors that put people at higher risk. So as Dr. Khanna had mentioned, there has been several studies done looking at risks of negative events postoperatively or in hospitalized patients. But most of those studies, the outcomes are not looking specifically at opioid-induced respiratory depression, but looking at respiratory compromise or respiratory insufficiency after surgery or deaths after surgery. So this table 2 is from the review of the literature from all of those studies. It's a comprehensive list of all the factors, when present, increase the patient's risk of OIRD. So we will see the items at the top are the strongest predictors. And as a matter of fact, we saw this in the Prodigy study also. Um, uh, 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 Obesity, hypoventilation syndrome, sleep disordered breathing in particular, part of the Prodigy factors. And then um, in in the literature, we also found that there's substantial evidence now that the first 24 hours after surgery is the highest risk period for surgical patients. And our ASPMN guidelines have stepped up to the plate and said, in the first 24 hours, all patients should have continuous monitoring after surgery. So there is really strong evidence to support this now. So recommendation 5. So far, the evidence-based recommendations that I mentioned had led to the importance of finding and detecting the person who is at higher risk. And we have a few tools to do this. Several tools are being used, but they aren't specific for opioid-induced respiratory depression. In particular, the Stop Bang questionnaire. That instrument is really validated to screen for patients for obstructive sleep apnea. And what we know is that there is evidence that using the Stop Bang may miss up to 18.3% of patients that show signs of opioid-induced respiratory depression. So specifically, what the study shows that postoperative patients, at least 18.3% of non-sleep apnea patients, so a sleep disorder, a Stop Bang questionnaire of less than 3, the developed moderate to severe sleep disordered breathing or opioid-induced respiratory depression after surgery. So now we have this validated tool, and Dr. Khanna went through all the various different items, but let's talk about how we can operationalize this in our facilities, and in particular in our electronic medical records. So this is the specifics that you can look for in your EHR. In particular, age, that's the age at time of admission. Sex, obviously patient reported. Previous opioid use. That information comes from the home medication list. If there is an opioid on that list, and it doesn't matter what the amount is, and if the patient is taking it on a regular basis, then that's designated as previous opioid use. Sleep disordered breathing, that's in the medical history, or a Stop Bang questionnaire of greater than 3. And then chronic health failure, of course, that's part of the medical history, or it can develop during the hospitalization. Medtronic has developed an app for the electronic health record that will help extract the data. And this is how it would look. If a person, a provider, entered a order for, in this case, morphine, the screenshot, this is a screenshot of what the app would look like. When the order is entered, there would be a pop-up of the Prodigy high risk score, and it would provide the components of that score for that specific patient. The provider then would look at that and say, oh, yes, is that correct? Is this information correct? And if it is, they can accept, and what would come up is then an order for respiratory monitoring. So once you accept that the score is realistic and appropriate for the patient, it'll trigger an order for respiratory monitoring. Now let me spend a couple minutes on policies and procedure development, as well as appropriate assessment and what type of monitoring would be more appropriate. So if the facility is going to institute risk screening, you must have policies and procedures to reflect appropriate patient care. So recommendation 7 states that the hospital administrators and administration must play a serious role in supporting safe and effective pain management. And if there's questions at the end about perhaps how we could use this instrument to get data on patients who are at risk at your own facility, we can discuss that. So adequate staffing, policies, procedures, purposeful rounding, and appropriate interpretation of electronic medical monitoring data are very important for our administration to support and enforce. And that means getting to the bottom dollar, the money, to get the equipment. So such policies and procedures should never reflect electronic monitoring replacing nursing assessments. We still need those nurses at the bedside and doing assessments at the appropriate timing. So the assessments should occur before administering an opioid, and they should include the level of sedation, respiratory rate, quality of breathing, oxygen saturation, along with the location of the pain and how the pain is preventing function. Functional assessments are a must to preventing adverse events. Nurses should never be medicating solely to a number. So number 10, the panel recommends that all patients deemed to be at risk of opioid-induced advancing sedation and respiratory depression be evaluated for continuous electronic monitoring, and that the electronic monitoring be appropriate for the condition of the patient, the presence of supplemental oxygen or PAP therapy, and also to the attention of the patient's response to care and their compliance with wearing the device. Patient comfort and adherence are very important. So this speaks to who should receive increased frequency of assessments and electronic monitoring. This recommendation is probably the most different from our original published guidelines. There are now sufficient evidence to support a more specific guideline for the use of electronic monitoring. In reviewing the literature and alerts from the Joint Commission on alarm fatigue and threats to pressure injury from monitoring devices, the work group had very thoughtfully and at times strained conversations about whether ASPMN was going to recommend electronic monitoring for all patients on opioids over the entire period of the administration of opioids. But the bottom line is that these guidelines advocate for a very individualized approach to selecting the safest patient monitoring strategy. And this recommendation supports using the correct type of electronic monitoring device and appropriate critical thinking and decision making of the bedside nurse. So just to very quickly reiterate the types of monitoring, pulse oximetry actually measures oxygen saturation and not particularly ventilation. It only is a validated measure of ventilation if it's added to respiratory rate. And the combination of parameters are always more better and more sensitive than just one measure. So to measure ventilation, you need capnography. There are other devices such as minute ventilation and transcutaneous carbon dioxide monitors that are newer to the field and not known as well to nurses and will require quite a bit of education. But they are measures of ventilation as opposed to just a measure of oxygenation. Now, let me tell you a little bit about some data that I received extracted from one of my studies. So what I want to point out are some downfalls of using just pulse oximetry. This is a study of PACU patients, and each graph is a different patient. So this was patient 3, here is patient 59. So green is pulse oximetry, and this line here is the threshold of 90% saturated. This is end-tidal CO2 with a threshold of 50. And this is minute ventilation with a threshold of breathing less than 40% of predicted for that patient. These vertical lines are opioid doses. So in particular, this patient came into the PACU. We put 3 monitors on them, and this is their data. You can see that they had 2 doses of opioids and then a repeat dose. This is pulse oximetry. It does nothing. It does not move from a standard of around 93-ish. And this is end-tidal CO2. So capnography, you can see that there is an increasing in their CO2 level. Again, pulse oximetry not moving. Here you can see that after these doses of opioids, a significant hypoventilation occurring. Again, pulse oximetry not telling the story. Some of this is likely because these patients are on supplemental oxygen. Now I want to give you the picture from this patient. Now look at this patient. Look at all the doses of opioids they received. Look at their breathing. This patient is not sensitive to opioids. This patient is more sensitive to opioids. This is what nurses need to be able to see on these electronic monitoring devices in order to really let the nurse see the big picture over time. This is over an 80-minute period of time, and it can compare baseline to what the current readings is. I call this trend monitoring, looking at saturations, end-tidal, minute ventilation over time. Now, we recruited 60 patients for this study, and what we noted out of the 60 patients was just like in the Prodigy study, 46% of these patients showed serious signs of hypoventilation from opioids. So there's 54% of the patients who weren't sensitive to opioids. And this was 2 other patients, the same scenario, oximetry not moving, capnography increasing, significant hypoventilation seen. So let me start to finish up here. The last two recommendations really stress the importance of clinician education, as well as developing policies and procedures. I'll let you read those yourself, and I will turn this back over to our moderator.
Thank you very much, Dr. Ljungqvist. I'm going to open both of your microphones so we can move on. What I will do now is remind everybody that this is a CME accredited session, and you can actually get your 1 hour contact hour from successtesting.com/init. You can see it there on screen. Go there, complete the requirements, and you will get your certificate. With that, I will also remind you that you will have this video recording available in about 10 days on this website that you see on screen, initiatives.patientsafety.org, and that will still be CE accredited for any other colleagues of yours that you may want to recommend this presentation. With that, I am going to open it to questions and answers. And we have a lot of questions from you. First, let me thank a lot of you from all over the world congratulating us for this event. Thank you, everybody. A special thanks and a big hug to Gabby in Thornton, Colorado, who is confined in her house there with her parents. And let's start with the following question that I'm going to pose for Dr. Khanna. Please keep your answers as concise as possible so we can answer as many as we can. Why are post-op events so common? Are we now not following ERAS protocols? Patients who are expected to have such events are monitored for longer periods in the PACU.
Yeah, it's a great question. So the question asks why these events are common despite not following ERAS protocols. My best answer to this is that yes, if you look at events, they don't happen in the PACU. The PACU is a monitored environment where everyone has all eyes on the patient. There's better nursing to patient ratios. But however, when patients go to the floor, then there's a drop off in the amount of attention, in inverted commas, a patient is getting, which is largely the lack of monitoring on the floor. That's the big difference between the PACU and the floor. And that's why we'll see events on the floor that typically happen about 24 hours after the patient has left the PACU. So while ERAS protocols are great and they will help us overall improve things, but monitoring without ERAS protocols is like doing, it's just incomplete still, and we need to implement both of those things to really have best outcomes for our patients.
Great, thank you. We have a question for Dr. Ljungqvist from Michelle. How do we score a patient on this tool if the patient reports they are a female but have male sex organs and are biologically a male?
Okay, so this is a non-evidence-based answer, but I would say that you have to go by their birth, the sex at birth would be my quick answer.
Thank you. Dr. Khanna, we go back to you and we say we are going to ask this. How did you assign the point value to the different patient clinical characteristics? For example, why is age weighted more heavily than CHF or SDB? SDB, I guess, is sleeping disorder, breathing.
Yeah, so the point values were assigned based on the multivariate risk prediction model and based on the amount of risk we saw based on every characteristic when it was placed into the model itself. And yes, age was, if you go back, look at the table, age in and of itself had an odds ratio of close to 4 as you got to an age greater than 80, and definitely the risk associated with age was much more than anything else.
We have this might be the $10 million question. James is asking the following, and I will open this question for both of you. How do we get the surgeons on board with this? Very few of the patients that I take care of have BMIs under 30. A handful have a diagnosis of OSA. Fewer use CPAP or BiPAP. And surgeons generally have no clue about the stop bank and primarily focus on patients throughout more cases in a given time frame.
Can I take this one, Dr. Khanna?
Sure, Carla.
Okay, so what I will say is that nurses are the ones at the bedside, and the nurses are the ones that have the ability to step up to the plate and say, look, this is what evidence shows. I've collected data on these patients, and between the data I've collected on these patients and the evidence and what is standard of care, this is what we're going to do to monitor these patients on the floor. Now, the other question comes to opioid-free anesthesia, and how do you get certain surgeons on board with opioid-free anesthesia? And I will hand that over to the anesthesiologist to try to deal with that.
Anything to add, Dr. Khanna?
Well, I think Carla makes great points there. I think you have to provide the evidence, right? And the worst, the one thing that surgeons don't like is hospital readmissions for their patients. They don't like unnecessarily prolonged stays in the hospital. They don't like their patients not doing well. So you have to provide them the evidence that here is the evidence in front of you. Here are the numbers that clearly show that monitor detected adverse events are associated with your patient staying in the hospital longer, a mean of 3 days longer. And no one wants that. And I would tell you that if you provide them the evidence, then it's easy to get them on board. You have to provide more evidence. Opioid-free anesthesia, it's probably a discussion for another day. I don't feel that there will ever be an opioid-free anesthesia. As an anesthesiologist, I can attest to that. There is a role for opioids intraoperatively, but we'll make progress on that. But certainly still doesn't mean that patients do not need better monitoring. It still means patients need better monitoring. We can do a lot of other things on the side, but not go away from monitoring.
Well, because it's the end of the hour, and we need to be conscious of everybody's time. Let me finish by repeating where you can go to take your C accreditation certificate. This is the site, and then remember that this will be on demand in about 10 days at this other link. With that, let me thank everybody for what you're doing out there in these very difficult moments. Thank you, Dr. Khanna. Thank you, Dr. Ljungqvist, for a great presentation. And with that, I am going to say have a great rest of the day to everybody. Okay, can you hear me, Aziz, Sharon?
Yeah, I'm still on.
Okay, yeah, I saw Carla left. Well, thank you very much, Aziz, for your collaboration. I mean, it was fantastic. Thank you. Thanks a lot. And well, we will keep in touch, okay?
Oh, absolutely. I'm sorry I went a little over my time and we didn't have a lot of time
Yeah.
for questions at the end, but it was just a
It was
pretty
okay.
intensive topic. Yep. But thanks
It was
again.
pretty good. Thank you, Aziz.
Thanks.
Take care.
Take care. All right.
Bye.
Bye.
Bye. Do this. Yeah, yeah. I did wrong. I shouldn't have done it this way. Okay, so now I'm going to, let me see if I close here, and webinar for all. That's it.